Next, we'll go to our session number 5, supporting disabled learners across the continuum of professional education. I'd like to welcome SMADIE board member and Stanford orthopedic resident, Dr. Claire Rushin.
Hi, everyone. Welcome to the conference. My name is Claire Rushin. I'm a white female with blonde hair in her 30s, wearing a blue top and a black jacket. And I'm pleased to be here moderating this session and introducing our first speaker. Her name is Hermione Warczak, and we'll be speaking about helping learners with psychological disabilities thrive on clinical rotations.
Hi everyone, I'm Dr. Hermione Warczak. I'm a white woman with shoulder length brown hair, wearing glasses and a white blouse. I'm currently an assistant professor at UMass Chan Medical School in Worcester, Massachusetts, in the Public Health and Preventive Medicine Fellowship. Clinically, I'm trained as a pediatrician and also as a public health physician. I was the president and founder of my medical school's disability affinity group. And I'm here to present today on helping learners with psychological disabilities thrive on clinical rotations. This is a topic that's near and dear to my heart as one of the first medical students who had any accommodations in the clinical portion of medical school when I graduated. And I was also able to help others medical students too through the disability affinity group. So for today, there are 3 learning objectives. So one is to talk about the barriers, so recognizing the barriers that medical students with disabilities encounter on clinical rotations, especially those that are less visible disabilities. Second is to describe accommodations for psychological disabilities on rotations to get a sense of what some of the disability accommodations are. And third, which is somewhat unique, is talking about how CARTs can function as an accommodation for disabilities that are separate from hearing or deaf disabilities. So the problems in third-year medical school is pretty clear. So clinical rotations are fundamentally different from preclinical coursework. Clinical settings can be pretty variable in environments, but they can sometimes be fast-paced environments with loud ambient noise and emotionally stressful situations and long hours. And learners have to interact with many different people. There are attendings, residents, fellows, nurses, other health professionals, students, and of course, patients. So accommodations in preclinical years, especially those that learners are used to from college and before sometimes, are not available in clinical settings or need to be set up in a different way to accomplish the same objective, which is what we'll be talking about today. So it's helpful to think about a standard approach to clinical accommodations for how to develop an evaluation with documentation of need and collaboration with the disability resource professional or DRP. So first is sometimes paradoxically one of the hardest steps, which is figuring out which functional limitations exist for learners due to psychological disabilities and how it's relevant for each rotation. So in terms of rotations, sometimes it's really just a short blurb is what learners know about the rotation, and it's hard to tell what exactly is going to be a barrier that should be removed or modified for rotation with accommodations. So a structured intake with a disability resource professional is really helpful here in terms of figuring out what those limitations are. And next is the collaborative process. There's the learner, there's the disability resource professional, there's clinical faculty that should collaborate to identify what these rotations are. I mean, the specific rotation barriers for each learner. And then engaging in the interactive process, which is so important to collaborate, develop accommodations that are reasonable and do not lower standards, but instead make it more practical and successful to obtain success in reaching those standards. So third year is notorious for very long hours, and scheduling accommodations can be really important for learners with psychological disabilities in order to manage health conditions and also to avoid situations that might worsen disabilities, such as prolonged night shifts with limited rest in between. So I'm mentioning that it's helpful to have it in the accommodation letter for scheduling accommodations that are needed for appointments. So this is because even though it's an LCME standard that learners need time off for healthcare appointments, it may be at a frequency or time that's considered less convenient for faculty, and faculty may not be aware of it as needed for disability. So it's best if faculty are made aware by having it formally in the letter. And for the same reason, it's important that it's specific so there are no surprises for faculty members. So the other is thinking about scheduling continuity and how it could worsen conditions. So rotations may have variable shift times, days, evenings, nights, weekends. While it can be an essential learning objective to learn how to succeed on call environments, it does not necessarily need to be overnight. It could be in the weekends or it could be in the evenings and during weekdays. So those are some ways to get that same experience as an accommodation. So patient presentations are known to be one of the most nerve-wracking experiences in medical school and are often a challenge for many learners, both with and without disabilities. So especially for making it a level playing field for learners with disabilities, it's really helpful to allow a momentary pause of 5 to 10 seconds while rounding or gauging Socratic teaching to allow time to think when answering questions or at the start of presentations. It's also really helpful to save all questions for the end of the presentation, not during it. Interruptions can disrupt the learner's train of thought. So this can be an extremely important accommodation. And the third would be to have access to written notes while presenting, which occasionally attendings prefer to have without notes. So it's helpful to know that it's a disability-related need. So time accommodations are related and often come up in this case. So the first is, so just thinking about in terms of extended time on tests, that's a very common preclinical accommodation. It's not intuitive always how this translates into clinical settings, but these are some helpful ways where it can translate with analogous accommodations. So the first is on inpatient rotations. It's always possible to have early notice of patient assignments before rounds because the patient will be there in the previous day or the afternoon, and it's possible to assign patients from that list to students so they have enough time to do pre-rounding. And extended time complete notes is also something that's possible to do, especially at home using a secure VPN on the same day, and then do feedback on the subsequent day. Next is scheduled and unscheduled breaks. Again, students all need some type of break, but to avoid any surprises for faculty and to ensure fair evaluations, it's helpful to have it as a specific accommodation and also making sure an appropriate location is available. So trauma-related accommodations is something that certainly comes up for learners, and it's also somewhat counterintuitive for people who aren't familiar with accommodations or how to make it work out as an accommodation. So one that's often possible to do is avoid seeing patients with a specific diagnosis. Faculty might push back on this one, but there is an alternative to meeting the same objective, which is it could be a simulated encounter or it could be in certain circumstances that make traumatic reenactment less likely. For the same thing, avoiding specific clinical sites sometimes is something that's important. So such as where a student was previously hospitalized, for example. And similar to what we were talking about before, a location for a private break is something that can be extremely helpful for those with trauma-related conditions, especially with how mostly stressful and all the stimuli that are present in clinical settings. So history taking accommodations. So the process of taking a verbal history of a patient's clinical presentation can be cognitively demanding. So learners with psychological disabilities might struggle with the process without approved accommodations to level the playing field. it's a little bit tricky here because any approved accommodation has to be HIPAA compliant and also must comply with infection control measures too, such as using a stereo cover for an electronic device running a stereo field. So two different possibilities here for note-taking accommodations. One is use an encrypted recording device that can be replayed at a later time. That's one option. The one that I used was the use of CART, Communication Access Real-Time Translation, that allows real-time captioning of the words that are spoken. So the way CART works, it's essentially subtitles for everyday speech. It captions all words, and if needed, can also caption sounds in the environment. So trained CART providers are familiar with medical terminology. I know my CART provider joked that she's been through medical school so many times that she should have earned a degree and her MD based on the number of times she's been through med school. So yeah, so it's extremely helpful. Medical terminology is accurate. The captions are high quality, and it uses a stenograph machine, not just typing. So it can be used in any setting. So I can say in terms of CARTs, so the literature does have one article specifically on CART in clinical settings. So not only does it help with retaining information that's presented in a clinical setting, but review of the transcripts can enhance physician communication skills from being able to read what the language is being spoken. So it's extremely helpful in terms of disability related effects in terms of attention and working memory. So it is something that is visible. So when I did it, I had an iPad that was the microphone and then a smartphone that was the captions to display it. So, but you can use a script like I use a live medical transcription service to ensure I capture every important detail of your history, a sample language that could be used. So just in terms of some reflections here, so learn about clinical rotation barriers for schools that have disability affinity groups. This is a great way for those groups to provide helpful guidance and advice to future students in terms of how to make accommodations work in clinical settings specific to that school and the rotations there. And second is don't wait to apply for clinical accommodation. It's really best to do it as soon as the very first clinical course of first year in order to develop accommodations that work for each student because every student is unique. And third, it's really helpful to have a good relationship with a disability resource professional in the school because there always may be unanticipated needs that come up, and it's helpful to have dialogue there when something does. So I think I'd like to conclude, rather than talking more about accommodations, to talk about universal design. So universal design is the concept that learning environments should be accessible and inclusive by design, not requiring accommodations for each learner with disabilities. So in clinical settings, it really helps everyone, but especially those with disabilities, to have things like highly specific rubrics for expectations with schedules provided in advance and early specific feedback to improve before it's the time of completing the evaluation. So the overall goal is transition from, does this student perform the way I'm accustomed to seeing, to can the student meet clients' needs competently and ethically, and what structures best support that outcome? So two things I'll say in conclusion. First, it's so essential to think about potential clinical barriers early and communicate collaboratively with the school's disability resource professional. Second, the culture really should embrace universal design principles. So in the words of Adele Duncan, a neurodivergent preceptor in speech-language pathology, quote, when programs design systems that expect variability rather than treat it as an exception, they are better equipped to assess what truly matters: critical reasoning, ethical judgment, adaptability, and care for those we serve. Neurodivergent learners bring creativity, empathy, insight, and resilience to our field. Moving beyond compliance-based accommodations towards intentionally inclusive design is an investment in the future of our field and the clinicians our communities deserve. So thank you.
Thank you so much, Hermione, for that very informative presentation. Our next presenter will be Kristen Blomquist-Liu, who will be speaking about patching the pipeline, universal design for learning to end the exclusion of neurological or chronic disability.
Hi, and let me get my screen started. All right, so my name is Kristen Blomquist-Liu, and I have been an occupational therapy assistant for about 6 years now. And a few years back, my wife and I decided to go to pursue our education pre-medical studies. And then in 2024, my wife was diagnosed with Guillain-Barré syndrome, and that really changed her health forever. Simultaneously, I was diagnosed with a later ADHD diagnosis, and the labs that we were really enjoying and just really excited to be in really started feeling like there were a lot of obstacles in them. And so we spent a few years of trial and error trying to figure out just some solutions that we have found effective. And so yeah, I just wanted to share that. And first, we have this pipeline. So when we were researching medical and scientific education for those with disabilities, we found that those were not, they were not able to, there is a gap with people that are able to finish their undergraduate degrees. And it's even less for those with graduate degrees. And you can see that funneling go on to 3%, just 3% of the STEM workforce identifies as having a disability. And then this also can present a gap in care. There are also 3% of physicians in the US identifying as having a disability compared to 29% of the US population. And then identity matched care has been proven to increase patient outcomes. So 2 in 3 patients have prefer a provider who shares their identity. And it was found that only 40% of physicians were very confident that they could provide equal quality care to those with disabilities. And there's really this gap here that we wanted to look into more. And with that, we're also looking, where are these gaps falling, especially in the laboratory settings, because that's especially where we found that to be a challenge. And sometimes at the standard physical accommodations that are kind of put in place in the laboratory environments, they're more reactive than proactive. And a lot of them can just be geared for more of the physical accommodations. But we have 80% of disabilities being invisible, and that includes the neurological conditions, such as in the case with my wife. And so we really just kind of wanted to look at what we could do to, like what these barriers are for inclusion. And some of the things that we've identified are chemical irritants and strong smells in the laboratory settings. This is especially, there's a lot of science, the chemistry classes, especially in the labs, that have to be done. And poor ventilation in those classrooms really can create a barrier. And then we have the visual stimulation that can be overwhelming. Bright screens, flashing or fluorescent lights, those can really, they're unavoidable sometimes, but we wanted to kind of look into what we could do, some simple solutions, which I will share later. And then also, there's just a lot of heavy kind of workload as far as the hours, the positional requirements, especially again in like the chemistry laboratories, kind of stooping over, standing for long hours. These were all just challenges that we found. And then it also goes into lack of flexible scheduling, and really to just a lack of awareness and support. A lot of this felt like we were carving out kind of our own accommodations and advocating for ourselves, because there just weren't a lot of things put in place that were helpful to help us stay in like the laboratory settings. And we also wanted to bring attention to this because not only are those with disabilities dealing with like the challenges that we've shared in the laboratory settings too, but also require 28% more income due to medical expenses. However, those with disabilities are paid less than their peers. So that is also a gap that is a barrier for people in the STEM fields. And then I wanted to just share some kind of low cost, highly effective solutions that we found that have really been helpful for us to be able to stay in classes. So task adaptations, mental rehearsal, chunking, these are all things that we have found to be helpful. Minimizing fluorescent lighting if possible. And then also too, for educators to be mindful to avoid flashing graphics, just really keeping in mindful perspective about like sensory, just being sensory friendly in the classrooms as much as possible. Also earplug uses, the loop earplugs, those are like a lifesaver for me. And then also being able to minimize mandatory standing, providing like alternative seating. These are the migraine glasses. This is what I've found for my wife. She uses these glasses fairly regularly, and they help her with the fluorescent lighting. And also just being mindful of temperature considerations. Like for her, she has dysautonomia, so those drastic temperature fluctuations can really be a challenge. And then another thing I wanted to bring attention to was green chemistry. These are practices that use safer solvents and chemicals and also are better for the environment. And when we did green chemistry experiments, it was such a game changer regarding even the smells. For me, like it feels very overwhelming sometimes to a lot of these chemicals, but the green chemistry, so advocating for use of that more too. And then also one thing that I've noticed too was in the laboratory, sometimes there's not really a safe place for a mobility aid to be placed, like out of the way, where it's also still accessible if needed. So designating spaces for mobility aids. Also normalizing the use of respirator masks, especially when we're around a lot of heavy smells. And also designating safe places to sit or rest, or even in my wife's case, faint. We had to carve out some places, like a safe place in the hallway where we would sit closer to the exit if that was going to happen. And then standardizing service animal protocols. And this is actually a picture of our service dog. We have a rough collie. She goes to classes with us, and she is so just incredible. She's a medical alert dog, but we've had to kind of carve out some of those kind of protocols because I don't think where we go there has been that many service animals. So really just standardizing that too. And then kind of in conclusion, it can be really isolating to be a person with a disability in science, and really just wanted to encourage the use of some of these strategies and advocate for mentorship too. We've had a professor where we go that has been an incredible mentor that has also kind of understood what it's like to have a disability in science, and then also just bringing awareness through events. Like this is just absolutely an incredible experience and opportunity, and to normalize pacing as well. That activity pacing, really just taking breaks as needed, making that okay. And then awareness and training. And then in conclusion, I'd also say it's a collaborative process. Everybody is the expert on their own condition. And I found that with my wife too. She's had to advocate for really what she needs, and for those educators and the disability service offices, really just letting the student be the one that is saying what they need. And that is it.
Thank you so much, Kristen, for sharing those thoughts. I have a question for both of our presenters. For learners, it can be challenging to anticipate what accommodation needs they'll require in environments they've never experienced before, things like the operating room or the laboratory. And how do you recommend that disabled learners advocate for their needs when they don't know or might not be able to anticipate what those needs exactly are?
So I think, so what I would do in medical school was figure out students who already did this particular rotation and talk to them about what it was like, what certain experiences were, and was there anything in particular that I was concerned about, how that unfolded in the rotation. So that's what I personally found most helpful.
And then I think for, like in the case of my wife, kind of just looking at too what her symptoms were, because it also changed what she needed each day. So if we knew it was a day where she was having more dysautonomia, if it was going to be a higher day of like a higher risk of passing out, just anticipating, okay, we're going to need to bring earplugs. But really that was where it was a lot of trial and error in our case, but definitely just, really trying to figure out what, and also like collaboration, like the DSS office where we go has been very helpful to kind of collaborate with, be like, these are the, what we're experiencing, how can we make this better and make it so that we can stay in school and do these classes. So that's ultimately, what we want to be able to do.
Great, thank you so much. A lot of our participants in the chat are bringing up universal design, and both of you discussed universal design as an improvement for the experience of both disabled and non-disabled learners. So how should educators balance ensuring equal access for disabled learners while normalizing the use of accommodations more widely?
So I don't think we're necessarily at opposing ends. I think it's certainly possible to do both. So normalizing accommodations is certainly something that can be done, and be mindful of those accommodations and follow them fully, while also just taking those steps to make the rotation from a universal design standpoint. So things like giving early specific feedback to learners and developing clear rubrics that have less subjectivity and are less subjective to negative bias towards disabilities are things that can be done, and they don't necessarily oppose one another.
I think we have.
Oh, what were you gonna ask?
Go ahead, please answer the question.
Okay, I was just gonna add to, with the universal design, again, having it be more proactive, just in general for the design of laboratories. And again, kind of that green chemistry, different things like that, to where there's less accommodations that even need to be provided when the classroom is just more accessible for everybody in general.
Great. I think we have time for one more question. So much of health professions education occurs at the level of the near peer, such as a resident educating a medical student or a senior medical student educating a clerkship student. What recommendations would you give to peers for creating a more accessible learning environment?
So something I would say is that the training provided to your peers is often considerably limited in terms of medical education skills. I think specifically including education on disability accessibility as part of that more limited training that your peers receive is something that could be extremely helpful.
Well, thank you so much to both Hermione and Kristen for this amazing session. I think I definitely learned a lot from both of you, so I appreciate you sharing your experiences with us.
Great. We'll take a break now until 1:45 for our next session.